Hi, today we will read about tonsillitis and adenoiditis. The tonsils are composed of lymphatic tissue and are situated on each side of the oropharynx. The facial and palatine tonsils and lingual tonsils are located behind the pillars of faces and tongue, respectively. They frequently serve as a site of acute infection, tonsillitis. Chronic tonsillitis is less common and may be mistaken for other disorders such as allergy, asthma, and sinusitis. The adenoids or pharyngeal tonsils consist of lymphatic tissue near the center of the posterior wall of the nasopharynx. Infection of the adenoids frequently accompanies acute tonsillitis. Group A beta streptococcus is the most common organism associated with tonsillitis and adenoiditis. Clinical manifestations. The symptoms of tonsillitis include sore throat, fever, snoring, and difficulty swallowing. Enlarged adenoids may cause mouth breathing, earache, draining ears, frequent head colds, bronchitis, foul smelling breath, voice impairment, and noisy respiration. Unusually, enlarged adenoids fill the space behind the posterior nares, making it difficult for the air to travel from the nose to the throat and resulting in nasal obstruction. Complications of this tonsillitis infection can extend to the middle ears by the way of the auditory eustachian tube, and may result in acute otitis media, which can lead to spontaneous rupture of the eardrums and further extension of the infection into the mastoid cells, causing acute mastoiditis. The infection also may reside in the middle ear as a chronic, low-grade, smoldering process that eventually may cause permanent deafness. Assessment and diagnostic findings. Physical examination is performed and a careful history is obtained to rule out related or systemic conditions. Tonsillar site is cultured to determine the presence of bacterial infection. In adenoiditis, if recurrent episodes of suppurative otitis media result in hearing loss, the patient should be given a comprehensive audiometric examination. Treatment. When medical treatment is unsuccessful and there is a severe hypertrophy, asymmetry, or peritonsillar abscess that occludes the pharynx, making swallowing difficult and endangering the airway, particularly during sleep, tonsillectomy is advised. Enlargement of the tonsils is rarely indication for their removal. Especially, most children normally have large tonsils which decrease in size with age. Tonsillectomy or adenoidectomy is indicated only if the patient is having following problems: repeated bouts of tonsillitis, hypertrophy of tonsils and adenoids that could cause obstruction and obstructive sleep apnea, such as an exacerbation of asthma and rheumatic fever can occur in some conditions. Appropriate antibiotic therapy is initiated for patients undergoing tonsillectomy or adenoidectomy. The most common antimicrobial agent is oral penicillin, which is taken for 7 days. Nursing management, especially postoperative care. The immediate postoperative and recovery period because of the significant risk of hemorrhage. Immediate postoperative period, the most comfortable position is prone with the head turned to the side to allow drainage from the mouth and pharynx. The nurse must not remove the oral airway until the patient's gag and swallowing reflex have returned. Ice collar to the neck and a basin and tissues are provided for the expectoration of blood and mucus. Bleeding may be bright red if the patient expectorates blood before swallowing. However, the patient swallows the blood, which immediately becomes brown because of the action of the acidic gastric juice. Hemorrhage is a potential complication after the tonsillectomy and adenoidectomy. If the patient vomits large amounts of dark blood or bright red blood at frequent intervals, or if the pulse rate and temperature rise and the patient is restless, the nurse notifies to the surgeon immediately. The nurse should have the following items ready for examination of the surgical site for bleeding: a light, a mirror, gauze, curved hemostasis, and a waste basin. Occasionally, suture or ligation of the bleeding vessel is required. In such cases, the patient is taken to the operating room and given general anesthesia. After ligation, continuous nursing observation and postoperative care are required, especially in the initial postoperative period. If there is no bleeding, water and ice chips may be given to the patient as soon as desired. The patient is instructed to refrain from too much talking and coughing because these activities can produce throat pain. Teaching patient self-care. Tonsillectomy and adenoidectomy usually do not require hospitalization and are performed as outpatient surgery with a short length of stay. Because the patient will be sent home soon after surgery, the patient and family must understand the signs and symptoms of hemorrhage. Hemorrhage usually occurs in the first 12 to 24 hours. The patient is instructed to report frank red bleeding to the physician. Alkaline mouthwashes and warm saline solutions are useful in coping with the thick mucus and halitosis that may present after surgery. Halitosis is bad breath. It is important to explain to the patient that a sore throat, stiff neck, and vomiting may occur in the first 24 hours. A liquid or semi-liquid diet is given for several days. Sherbet and gelatin are acceptable foods. The patient should avoid spicy, hot, acidic, or rough foods. Milk and milk products, ice cream and yogurt may be restricted because they may make removal of mucus more difficult. The nurse explained to the patient that halitosis is bad breath, and some minor air pain may occur for the first few days. The nurse instructs the patient to avoid vigorous toothbrushing or gargling since these actions could cause bleeding. Thank you.